suspected biliary cystadenoma, do we biopsy it? Is that what you're asking? We do not, because being predominantly cystic, you're unlikely to get positive tissue from the wall. It's really paucicellular is a term that the pathologists use. So it really has to be a diagnosis where you're highly concerned about it. The surgeon will operate. It really should only be done in a place where they really have expert liver surgeons. There are certain, interestingly, when you talk to surgeons and so forth, there are certain kinds of lesions that they can recognize rising from a kidney or a liver, that they're like blue dome cysts that are in the kidney that are almost always the benign sort of cysts and so forth. So they have certain features when they actually even look at them just grossly that help to confirm that this is a worrisome lesion and needs the aggressive surgery. Yeah.
So just as an add-on to that, we've seen a spate, it's not common, but we've seen more of these IPNBs, the intrapapillary biliary neoplasm. They look like a malignant IPMN of the pancreas, but I've seen, and I've seen from other places now, dozens of cases total. Every single one I've seen has involved the left hepatic lobe, where it dilates the left hepatic and goes into the extrahepatic. I'm still looking for a right hepatic case, but those are very analogous to the IPMN of the pancreas, but they can be mixed though. Sometimes you'll see a biliary cystadenoma component to that, or how often are you seeing that IPNB versus classic biliary cystadenoma? Because we're seeing more of those than the classic other.
In the 45-minute version of the cystic liver mass, that's the second last entity that I talk about. But basically, if you take everything you know about IPMN of the pancreas and think of that as being a horizontally oriented duct, now turn it vertically, now you know what you need to know about biliary IPMN. And it's the same sort of thing. It can range from benign hyperplasia of the mucus secreting glands up through a malignancy. The malignancy, when it develops, is a cholangiocarcinoma. They can be pretty aggressive. Just as within a pancreatic IPMN, you see gross dilation of the biliary tree, and if they do endoscopy, they see a lot of mucus coming out of the duct. So I agree with you. I went years without seeing any of these, and then I think I've seen 4 in the last year, and I don't know what that's all about.
Okay.
No comment.
Yeah.
Okay, so you're on CT, and then you get this follow-up low-dose CT lung cancer screen. And you pull up the report, and someone has identified 10 nodules that are maybe 1 to 2 millimeters on an axial study. And you just feel like you would wish you were in Las Vegas for the evening. And then you go, how do you handle this? Because you look at them and you go, this really isn't a nodule, minus the periphyseal nodules. And sometimes you go to the MIPS and it's like, okay, where's the nodule on the axial images? So what do you think about that? Do you think that's like an Overreaders Anonymous, or identifying 1 to 2 millimeter?
So you're saying there are, just because, and that's a great story. I'm just trying to figure out, so you're saying there are 10 1 to 2 millimeter nodules? Is that what you're saying?
Yes.
Or at least theoretically there are.
They're making them, oh, well, yeah, well, we have people on our different parts of the ROC curve, as I like to say. We have people, and we say, oh, that's Dr. X who just read, and I'm like, we wink and nod and say, and we do.
Yeah, okay, so the question is, I guess maybe we even make it a little bit simpler. We could say is, what do you do with someone, when the person who read the scan before you said, recommend follow-up for these quote-unquote 1 to 2 millimeter nodules, multiple ones?
So honestly what I do, and we have somebody exactly in my group that does stuff like that, not all the time, but it does happen. And in any event, I just say the nodule is no longer visible and no follow-up is recommended. That's what I usually say.
Well, yeah, I'll tell you where this is a really big problem. So at Hopkins, we do a multidisciplinary pancreas conference, and when the patients come in for their evaluation that morning, they do chest and abdomen. Now, the presence of a lung nodule theoretically will not affect either survival or even management. But what happens is a lot of times some people, it's always that some people, read a number of questionable 1 to 2 indeterminate nodules, advice clinical correlation or something like that. And it's kind of when I read them at conference, I just say it's nothing, next case. Yeah. But it's not, I mean, we joke about it right now, but it's a tremendous problem. It's also a tremendous problem for oncology because the presence of a lung nodule changes everything. And, all of a sudden, so how do you do with that, Charlie?
It makes a difference also. Does the patient have a known malignancy? You were talking about in a screening setting, perhaps. Yeah, and I would tend to say, I often will say, and I might not say is no longer, I might say is not identified, no, the bottom line though, if it's a 1 to 2 millimeter nodule, it's a 1-year follow-up, correct? And if there's no nodule, it's a 1-year follow-up. So in a sense, in a screening setting, it doesn't make any difference. So you can phrase it how you want in the body of the report, but you're going to recommend a 1-year follow-up because it's a screening study. Because that's the standard. So in a screening setting, it doesn't make any difference in terms of what you say. You're just going to try to be polite to your colleague, and the best way, in my view, frankly, is to go along something along the lines, it is not currently identified. There are lymph nodes that disappear. Even if let's say we give them the benefit of the doubt, that they saw it and you didn't see it, and or whatever, it was there and somehow digital imaging dropped it over the course of the year or who knows what, and you now just don't see it. So it doesn't matter. You can just say that it's not currently identified and move on.
Yeah, so maybe we can get Mike and Perry's comment, because just to expand it, where I think it's real, okay, it's one thing in the lung screening category, right? You can bring the patient back a year later. But my concern is both liver and lung, where you have a patient with pancreatic cancer, and name any cancer you want, and someone reads it, too small to classify liver lesions, and multiple 1 to 2 millimeter lung ditzels, nodules, whatever, because then all of a sudden you're taking a patient where you might have a colon cancer that's a stage 1, and now you're making it stage 4, theoretically.
Let me address the lung for that, because I did mention the screening situation. So yes, so now let's say we have some kind of breast or abdominal malignancy, and somebody mentions that. Again, then you might recommend a short-term follow-up, or they will have gotten a short-term follow-up because of this previous nodule. Could this be an early met? That nothing will, again, happen until you look at it, because nobody is going to act on a 1 millimeter nodule. At least this is a lung thing. Now I'll turn it over to the abdominal guys.
So let me give you a pearl that I use just about weekly when I'm reading cancer cases all day. So you have somebody who has colon cancer, and I'm distinctly talking about colon, not rectal. I'll talk about that in a minute. Patient has no liver metastases, and there are a couple of little nodules in the lung. And almost invariably, I'm reading out with a new fellow or a resident, they say, well, can't rule out metastases. And I say, all right, think about it. Patient has no liver metastases. What are the odds, just by Bayesian sort of analysis, that these are lung metastases? And they go, I don't know. And I say, practically 0. So here's what you're going to dictate, that these lung nodules are probably not metastases, and they ought to make their judgments about what to do about I'm implying that they should make the judgment about what to do about the colon cancer based on the presumption that those are not metastases. Unfortunately, you can't use the same reasoning for rectal cancer, because rectum has both systemic and portal venous drainage, and I've seen plenty of patients with rectal cancer who have lung mets and not liver mets. But with that exception, I use that kind of reasoning a lot.
But would you get a full chest CT in that, or would it depend? What about with the rectal versus the colon? Would you?
With a rectal cancer, I might have to. For colon cancer, absolutely not.
Yeah, and I would just agree with what Mike and Elliot are saying in terms of clinical practice. I think we need to strongly word our impressions, and I agree with that reasoning. I think too many times we just get sloppy or lazy, and there's huge difference between cannot rule out versus highly unlikely. And what I like about the multidisciplinary conferences, I do colorectal just about every week, hepatobiliary more often than I want to as well, but because they're mostly pancreatic cysts now. But in any case, what's great is face-to-face, you can easily convince your colleagues, they know me, and I'm just like, don't worry about those. I mean, we can just follow those up with their imaging down the road, but don't change your management based on these DITSLs. And I think that comes across so easy in this face-to-face multidisciplinary, and they're always like, oh yeah, good, thanks. But from a report, they are sometimes just handcuffed.
So let me just follow with Perry's thing. And I agree 100%, but the real challenge, I think Mike mentioned it yesterday, and we may have mentioned also when we were discussing it yesterday, is what we leave out is, okay, so when I'm in multidisciplinary, they show this, they said nodules, okay, next case, move on, no, nothing, okay? And everyone forgets about it, but the problem is the patient all of a sudden reads their report, and they read the report that says it could be lung mets. That's not what the clinician told them. They think, oh my God, I'm surely going to die. I thought I had localized disease. Now it's spread.
So let me add another. My residents and fellows know that they cannot get through a readout session with me without some rant and story. It's just a given. It comes with age, yeah. But let me give you a real life case. First of all, I've had 4 family members misdiagnosed with cancer with lots of bad outcomes as a result. But one of them, my brother-in-law, lives in Cincinnati. Mind you, this is important. And he gets an unneeded CT scan of the abdomen and pelvis, and the radiologist has incidentally noted are several non-calcified pulmonary nodules in the lung bases, cannot rule out metastases. Not only does he read that, but his insurer reads that. Now, my brother-in-law is a self-employed architect, so he pays outrageous amounts of money for his insurance right away. Over the course of the year, his insurer drops him for no good reason other than that lousy radiology report. And for 5 years, he pays these enormous rates because there is a sort of presumption that he is at risk for metastatic disease and may in fact already have metastatic disease. So there are real world consequences about giving unnecessary hedgy things. Now, the other thing is, use a little common sense. He lives in Cincinnati. I grew up in Cincinnati. We all have histoplasmosis, for Christ's sake, right? So we all have pulmonary nodules, and if you don't apply some reasoning, so thank God we have guidelines, Fleischner and others, to help us apply some reasoning, because if you're just going to finish every report with can't rule out metastases, you're doing a huge disservice to patients.
Okay, let me move on. Here's a follow-up question.
Well, no wonder the clinicians don't order these CT scan, low radiation dose, because you get the report, and it's not just a couple radiologists that do it. They're identifying 1 or 2 millimeters that are really not there. And why does a clinician want to look at a report where there's 10 references to nodules that are really not there? And then the patient gets upset that the patient has nodules.
So rephrase it in the form of an answer. Clinicians hate reading reports about multiple, too small to characterize nodules, whether in the lungs, the liver, the kidneys, et cetera. And then we think, we got the monkey off our back, we've lateraled the ball to them. They totally hate it for good reason. Many times they think we're doing nothing more than covering our ass and asking to do additional unnecessary imaging tests. So I think we need to avoid that stuff.
Well, and also I think it sounds like this is in a way an extreme of what we were talking about, where somebody is actually, one or more of the radiologists are making up nodules, if you will, or imagining nodules when they're not there. There, I think you really have to have a discussion with the radiologist involved, and maybe, a recentering of what their position is, a retraining, or having them sent to a course like this, or who knows what, so that that's not going to be acceptable really in the long term. I don't think.
Well, I have to go. I'll make one last statement on that. Is we had one radiologist a number of years ago who left. When that person never read a report that didn't recommend 3 other studies. When they left, our departmental volume went down 10%. So, okay, let me ask one. There's a question online here. So this is for Perry. Do you have, and this is a great question related to the fatty liver. Do you have a specific method you recommend follow each time for measuring the liver on non-contrast CTs, such as a single site at a specific location, multiple sites, average, and I'll add on one thing, what's the size of the cursor you typically use?
No, that's great, because we've done so many, just thousands and thousands of measurements that we wanted to make it as simple as possible without somehow missing important data. And this has been done with CT and MR. You know, some studies have thrown on ROIs in every single liver segment, right and left, whole volume, half volume. And we've done some of those studies, and remarkably, unless there's visual, there are those cases where there's visual heterogeneity that's obvious, right? There's a regional difference that's related, like you see with THIDs and THADs. There's fatty differences that are geographic. And that aside, if you take just a representative single ROI of the right hepatic lobe, sort of in an area where there aren't vessels, it does remarkably well to just give you the general, I mean, whether it's off by a Hounsfield unit or two from the whole volume, or I don't think it matters. So I think it's really simple just to do that. I'd recommend it to be as big as possible within that homogeneous area. And I think that gets to be about 500 square millimeters. I can't remember exactly. I take that off my, I only have mean show up. All the residents will have min, max, median, you know, and all these things. It's like you don't even know which measurement matter or which. So I take all those off. But anyway, so I forget how big things are. But when I write papers, I always have to go back and say, oh yeah, how big is that? So I think it's about 500, maybe even up to 1,000, as long as you're not including heterogeneity, and it works remarkably well. And this isn't rocket science. We're just trying to give like a rough, you know, like if you're within 5% one way or the other, I think that's more than adequate. Plus, it does, you know, what it matters, I'm not sure, but clinicians, some do want to know fairly precisely, and they want to follow it, and that would be my recommendation. Just be as simple as possible, except for those cases where you have to think a little harder if there's true regional differences.
Okay. So we're out of time, but I will say, because Perry and Charlie will be back later for Q&A, this is Mike's last Q&A, so if anyone has one last question for Mike, this is the time. Going once, going twice. Coffee time. See you in 15 minutes.
Go to coffee. I'm going to make a little comment, however, on one of Perry's things about fibrosis. So we've experimented with a variety of ways of measuring fibrosis with ultrasound elastography and MR elastography. We had a lot of unacceptable variation among the ultrasound techs and equipment, so we really had to standardize that. What's your current feeling about imaging studies to measure elastography?
Well, if you were here this afternoon, I have a whole talk on. We do a lot of ultrasound and a lot of MR, and I too, I bring it to conference all the time. There's measurements that are just so far out of whack with reality of what the morphology and sometimes what the MR will show, that I have an issue with ultrasound that I haven't quite figured out yet. And it's also the actual kilopascal measures are the scales are different, so we're not even measuring the same thing. So I don't have a good answer because I'm still struggling with it. I don't believe in ultrasound other than to get it sort of right most of the time. But yeah, it's a frustrating.
And Perry will pick that up at 2 o'clock this afternoon.
I'll give you the full answer later.
All right, have a great break.
Jesus, we had such variability. I mean.